Hi, everybody. Thanks for joining in. I'm going to keep my bit to a minimum and just say thanks for signing up. We're going to make a start in just a moment, and I'm going to hand over to Toni. The webinar is being recorded just so that we can share it afterwards so that people can get the maximum benefit from it. I'm sure that Toni won't mind you asking questions of him after the webinar and ourselves. At the end, we've got a code for 20% off all of the Celox products online until the end of November, so please do stick around for that. Toni is well known in the industry for his delivery of bleeding control training, and I think probably one of the forefront in that field. Toni, is that fair to say?
I think I'm it for the UK, actually, Sam.
So this webinar is bleeding control by the person in bleeding control in the UK. So without further ado, I'll hand over to you, Toni, and I'll pop back up at the end with the discount code and things. So thanks very much, Toni, and please feel free to join in the chat and ask any questions as we go through.
Thank you very much, Sam. Let's crack on to the first page here. So good evening and welcome. Just say we start promptly at 1900. As Sam mentioned, if you do have any questions, if you look somewhere in the middle of your Zoom screen, you'll have a Q&A section. Please feel free to sort of type in questions in there. We'll answer them at the very end. Now, if you want to ask anonymously, because I do like to read people's names out as well and try and have a chat to them, then you can ask anonymously as well. Remember, there's no such thing, I think, as a daft question. There's a lot of things around hemorrhage control. There's a lot of things to take in here. You may well find as you go through that a lot of the things you're thinking about and the questions are actually answered as we go through the rest of the presentation. This presentation has been in development for some time now, and actually it's an accredited course by the Faculty of Pre-Hospital Care, Royal College of Surgeons as well. I would also recommend very much that you do try and get some hands-on training. For anybody that's interested in that, again, contact Sam. He'll put you in contact with myself, and we could potentially come down and run a hands-on training session with you, where we'll bring various simulation aids down there and talk about packing wounds and putting tourniquets on you, etc., etc. There is a learner's handbook that goes along with the course. It's External Hemorrhage Control, a Stepwise Approach. Again, it's endorsed by the Faculty of Hospital Care. It's about 93 pages off the top of my head. And it basically sort of covers everything that you're going to do over the session. It does it in a little bit more in depth for you as well. So it's a really good accompaniment to this. And these are available via e-commerce sites as well. Do feel free to follow us. I'm pretty sure you're already following Sam on there with Reflex Medical. Celox Medicals on Facebook. We're on, I think that's Instagram, the next one. I'm getting on a little bit right now and don't always understand these. We're also on LinkedIn, and people can find me personally on LinkedIn. I'm more than happy to ask questions on there. If anybody wants to find me, and I'll jump on there and ask questions as well. I believe we're also on Twitter. Again, I have nothing to do with these as much as I'd like to. So we do publish things on there in regular courses. And out of interest, we do have a brand new product that's out as well, a chest seal. It's a vented chest seal, multiple vents, 512 potential pathways for air, blood and snot coming out of. It's a fantastic new product, and there's going to be a course that's being delivered very, very soon to accompany that as well. So please keep an eye out via social media for that course. It's a full chest injuries program. It'll cover absolutely everything. And for those of us that are medical professionals will remember things like 12 flaps in the low R and all this good stuff. I think really without further ado, let's crack on. Hello and welcome to our Hemorrhage Control Principles course. So for those that don't know me, my name's Toni. I'm a paramedic. I've been practicing now for over 30 years, both in the military and civilian environments. I've worked in some very hostile and some very remote areas, including Iraq, Afghanistan, North Africa, South Africa, the North Sea, Norway, and the mean streets of West Yorkshire. I'm currently a subject matter expert in hemorrhage control, working directly for Medtrade products. So why are we here? Just think about that for a minute. So we're here to learn about hemorrhage control and, in fact, our stepwise approach. We're going to update your knowledge on hemorrhage control, and for some, that'll just be continuing professional development. What we want to think about is this. The biggest killer in trauma-related deaths is hemorrhage. Over 70%, in fact. Think about knife crime. Knife crime across the UK. It's a growing problem. And actually, the majority of deaths related to knife crime are, in fact, hemorrhage. Let's also think about terrorism. I was at a conference not so long ago, in fact, the Major Incident and Emergency Response Conference. The premise of the whole conference was it's not a case of if it happens again, when it happens again. So, in today's session, I'll be explaining what hemorrhage is, we're going to understand the circulatory system and types of bleeding, how to control hemorrhage and how to use tourniquets, and ultimately the use of hemostats, what they are, how they work. Let's dispel a few myths for you. And as I said before, the practical session will be held at a different time for you. The objectives: by completing this course, you'll have a full understanding of how to identify catastrophic hemorrhage, how to manage it using a stepwise approach to hemorrhage control, and we'll also go through how the stepwise approach can be used to stop bleeding in a first aid situation. So you've got the knowledge on how to deal with the bleed at either end of the spectrum. To make sure you have a real understanding of the stepwise approach, you're then going to put this into practice in the next session. I'm going to use tourniquets and hemostatic control products. So why are we concerned about hemorrhage? Well, in 2017, the US Centers for Disease Control and Prevention, the CDC, they announced that injury was the leading cause of death among persons aged 1 to 44. To break that down further, uncontrolled post-traumatic bleeding is the leading cause of potentially preventable death among injured patients. And the bleeding trauma patient represents a significant financial burden for society. A study conducted in 1994 by Hussain and Redmond found that 39% of pre-hospital deaths between 1987 and 1990 were from accidental injury. These deaths might have been preventable with the provision of basic first aid. This study has been repeated more recently by the British Red Cross, who released the following statement about their findings. So when compared to the 1994 study findings, using the same historic analysis for probability of survival, study 1 found that 43.3% of people had a probability of survival greater than 50%, compared to 39.5% in the 94 study. When the more recent analysis method was used to calculate the probability of survival, study 2 found that between 45% and 59% of deaths were potentially preventable. And that's according to World Health Organization definitions. The percentage of potentially preventable or preventable deaths remains high and unchanged since 1994. And although calls for assistance were made in up to 93% of cases, first aid intervention of any kind was infrequent. A bystander or passerby was on the scene during, immediately after, or in the minutes after the point of injury in up to 52% of cases. However, when those found dead are excluded, a first aid intervention was attempted in between 43 and 57% of cases. This is despite the injured potentially being alive at this stage. This presents an opportunity to help, but is often a missed opportunity. What you need to think about is sometimes the most important person is the people that you train. These are the first aiders. And genuinely, first aid makes a huge difference. And I think for the guys here that are paramedics and medical professionals as well, you'll know that when you go to the scene of an accident, the scene of an incident, and things like CPR are being in progress, you'll know the difference that makes. So let's have a brief look at the circulatory system. Severe blood loss can disrupt the circulatory system, and as a result, this could lead to a failure in providing enough oxygenated blood to the body. And this deprives the vital organs of oxygen. The heart alone is capable of pumping over 5 litres of blood around the body every minute. And the rate at which your heart pumps blood around the body can increase because of exercise or stressors. It's like adrenaline, in fact. Because of this, in the event of an injury, it is likely that the injured person will pump even more blood around the body. We all know that the pulse tends to go up. The size of an injury does not necessarily matter. As the first aid provider, you should look to ease and calm the person with an injury to slow down or control that blood flow. The circulatory system is made up of 5 core parts. Have a look at these: the heart, blood, arteries, veins, and capillaries. Let's look at them individually. So the heart, as we know, it's the main pump of the body. It's the only pump in the body, in fact. And it's about the size of the owner's own fist. It's located on the lower left side of the chest. The right side of the heart receives oxygen-poor blood from your veins and pumps it to your lungs. So the blood enters via the superior and inferior vena cava into the right atrium. From the right atrium, it goes via the tricuspid valve to the right ventricle, where it's pumped out of, in fact, the only arteries in your body that carry deoxygenated blood. These are the pulmonary arteries. Pulmonary arteries go straight to the lungs, where it picks up oxygen and gets rid of carbon dioxide at a cellular level. It then enters the left side of your heart by the left atrium, or the oxygen-rich blood. It goes via the left atrium to the left ventricle, and then it's pumped out forcibly by the contraction of the left ventricle, via the aorta, and around the rest of the body. Have a look at the Learner's Handbook for any more information on that. Blood cells. Blood consists of blood cells. There are 3 major types of blood cells that allow the circulatory system to function properly. These are erythrocytes, or red blood cells, and these primarily carry oxygen and collect carbon dioxide through the use of hemoglobin. Leukocytes, or white blood cells, they're cells of the immune system, and these protect against infections and foreign invaders. And then thrombocytes, or platelets, which are very small, irregularly shaped, clear cell fragments. As blood is pumped around the body, it is contained within tube-like structures known generally as blood vessels. The circulatory system contains 3 distinct types of blood vessels, each of which plays a different role in the flow of blood around the body. These are the arteries, veins, and capillaries. Have a look at the image. The arteries are the blood vessels that deliver oxygen-rich blood from the heart to the tissues of the body. The largest of these, obviously, is the aorta that comes directly from the heart, and that's about the diameter of this. A lot of blood travels through it. Each artery is a muscular tube lined by smooth tissue and has 3 layers. The intima, the inner layer, which is lined by smooth tissue called endothelium. Media, a layer of smooth muscle that lets arteries handle the high pressure from the heart. And the externa, or the adventitia. This is connective tissue connecting arteries to nearby structures and tissues. Again, for more information, please go into the Learner's Handbook. Veins. Veins are again elastic blood vessels that transport blood from various regions of the body back to the heart. So again, within the scope of this course, we've categorized into 4 main types. Pulmonary veins carry oxygenated blood from the lungs to the left atrium of the heart. Systematic veins return deoxygenated blood from the rest of the body to the right atrium of the heart. Superficial veins are located close to the surface of the skin and not located near a corresponding artery. And then deep veins, which are located deep within muscle tissue and are typically located near a corresponding artery, like the brachial, axillary, and femoral. Deep veins carry the vast majority of blood. The disruption of these can be life-threatening. There's many other types of veins, but again, please look at the handbook. This brings us on to the next part of the circulatory system. So capillaries are the smallest of blood vessels. Their purpose is to distribute oxygenated blood from arteries to the tissues of the body and to feed deoxygenated blood from the tissues back into the veins. The capillaries are therefore a central component of the circulatory system, essentially between the arteries and the veins. Have a quick experiment now. Grab your nail bed and I want you to squeeze it. It should look nice and pink. Give it a really good squeeze, a few seconds, have a look, it'll go white, and then it'll turn pink again, usually within 2 seconds. That's what we call capillary refill. Mine's all nice and pink again. So I'm teaching you to suck eggs. These are different types of bleeding. Think about arterial, blood spurts out, usually in time with a heartbeat, and it's usually bright red and sometimes frothy. Venous bleeding. Venous bleeding, it flows out, and it'll flow out quite a lot. Again, it tends to be a sort of darker in colour. And capillary bleeding, the blood oozes. For a lot of us chaps, and in fact I've just shaved mine off and cut myself several times bleeding, that's capillary bleeding. So when we first looked at the circulatory system, we looked at the 3 different blood cells. Platelets or thrombocytes, as we referred to them earlier, are blood cells that start clot formation. This is activated by chemicals released by damaged blood vessels. This brings us nicely to the intrinsic clotting pathway, which basically is when blood clots form to help prevent leaking when you break the surface of the skin. For example, when you cut your finger chopping vegetables or on a piece of broken glass, your body goes through a certain series of events to make sure that you do not bleed to death. The stages of platelet plugging can be summarized in 3 parts. Adhesion, that's the platelet to the endothelium. Activation of the platelet, releasing enzymes, proteins, and other nutrients. And aggregation, that's platelets and red blood cells. They're forming a plug. Think about that now. That's your clot. Coagulation then. Coagulation refers to the process of forming a clot to stop bleeding. Coagulation is a complicated subject, and it's greatly simplified here for students' understanding. To stop bleeding, the body relies on the interaction of 3 processes. Primary hemostasis involves the first 2 processes. That is vasoconstriction, which is the body's first response to injury in the vascular wall. So when an injury occurs, vessel walls constrict. This causes reduced blood flow to the site of injury. Platelets aggregate to the site of the injury and stick together to act as a plug. These platelets also activate the process which causes a fibrin clot. This is known as secondary hemostasis. So secondary hemostasis. Platelets alone are not enough to secure the damage in the vessel wall. A clot must form at the site of the injury. The formation of a clot depends upon several substances called clotting factors. These factors are designated by Roman numerals. That's 1 through to XIII 13. These factors activate each other in what is known as the coagulation cascade. The end result of this cascade is that fibrinogen, soluble plasma protein, is cleaved into fibrin, a non-soluble plasma protein. The fibrin proteins stick together, forming a clot. The coagulation cascade then occurs through 2 separate pathways that interact with each other. That's the intrinsic and the extrinsic pathway. The extrinsic pathway is activated by external trauma that causes blood to escape from the vascular system. This pathway is a lot quicker than the intrinsic pathway, and it involves factor 7. The intrinsic pathway is in fact activated by trauma inside the vascular system. This is activated by platelets, exposed endothelium, chemicals, or collagen. This pathway is slower than the extrinsic pathway, but a little bit more important. It involves factors 12, 11, 9, and 8. And the common pathway. Both pathways actually meet somewhere in the middle, and these finish the pathway of clot production in what is known as the common pathway. The common pathway involves factors 1, 2, 5, and 10. Ultimately, at the very bottom end of here, you can see fibrin, fibrinogen, fibrin polymers, until we get to a cross-linked fibrin polymer, which is a very fancy way of saying a scab. So let's think about factors that affect the natural clotting mechanism. These are collectively known by the medical term trauma-induced coagulopathy. Have a look at the diagram on the left. And again, for more information on that, please refer to the handbook. It's quite complicated, and I do know a good Professor Porter can talk about this for hours on end. What about other factors then? Blood thinning meds, anticoagulants, warfarin, apixaban, rivaroxaban, aspirin, very, very common medications, especially in the older end. Chemicals react better when they're warm, in fact. And the cold and hypothermia could prevent blood from clotting. And this results in a coagulopathy as well. So according to statistics, coagulopathy occurs in 1/3 of all severely injured patients on presentation to the hospital. This leads us on to the trauma triad of death. The trauma triad of death is commonly seen in patients who sustain severe traumatic injuries. The three conditions on here share a complex relationship, and each of these factors can compound the others, resulting in a higher mortality if the cycle continues uninterrupted. Severe hemorrhage in trauma diminishes oxygen delivery, and this may lead to hypothermia. This in turn halts the coagulation cascade. Let's have a look at this. Here's your coagulopathy at the top. This could be trauma-induced coagulopathy. It could be drug-induced. It could be a hypothermia-induced. This increases lactic acid in the blood. That lactic acid increases acidosis. That increase in acidosis decreases the heart's performance. Think about the other factors that are kicking in now. You've got a patient that's shocked. He will be shut down. He will be pale. He will be cold. He will be clammy. And because of that decreased heart performance, that'll lower the body temperature even further, creating hypothermic patients. Ultimately, that hypothermia decreases coagulation, and this goes round and round and round until you die. Think about the severity of bleeding then. Life-threatening bleeds range from internal organ bleeding to massive varicose vein bleeding. You may observe bright red blood spurting in time with a heartbeat. That's going to be quite life-threatening. We would say usually within the first sort of 5 to 10 minutes. Think about dangerous bleeds, large wounds that are continuously bleeding. Foreign body impalement. What do we do with foreign bodies? Of course, we leave them in, don't we? We know that. Think about open fractures. How much blood do you lose from an open fractured femur? Answers in the chat room on that one. Minor bleeds, generally bleeds just require a bit of cleaning and dressing. Think about lacerations, abrasions. You know, we give them a clean up, don't we? Pop a little dressing on them and they're fine afterwards. So what is the fastest killer then? Arterial, venous or capillary? Well, arterial wounds can kill you very quickly. Also, uncontrolled venous bleeding can kill you. And capillary bleeding is usually very, very minor in nature, unless you're on fancy medication that can make it bleed for even a long time. So how much time do you actually have then? If a person loses over 40% of the total body volume, then this is considered class 4 hemorrhage, and it could be fatal. Depending on the type of injury and the amount of blood loss per minute, you will have varying amounts of time to treat the hemorrhage before it becomes fatal. Remember the 3 goals of first aid. Preserve life and alleviate suffering, prevent further illness or injury, and promote recovery. First aiders need to act as quickly as possible to achieve these 3 Ps. So in actual time frame, the heart pumps approximately 70 mils with every beat. And it'll beat an average of 80 times per minute, with each beat pumping about 0.07 litres of blood around. If we do the sums, that's 70 times 80, which equates to about 5.6 litres of blood per minute. Funnily enough, that's roughly what the actual amount of blood in a human body is. So your complete blood supply every minute circulates around the entire body. Blood flow from the femoral artery, which happens to be the size of your little finger, is about 1.5 litres per minute. Open up the femoral artery in an injury, you will lose every single drop of blood from the body in 3.7 minutes. Think about that. Open up the carotid arteries at the side of the neck. There's 4 of these, 2 external, 2 internal. 0.5 litre per minute goes through each of them. Just open up one and you can do the sums. But you're going to die well before that. And that's why we need to be speedy with our treatment. So Dr. ABCDE then is a step-by-step approach that should be used by first aiders for most situations. However, depending on the severity of the injury, first aiders may need to take a different approach. And to explain this more clearly, we're going to look at medical first aid on the battlefield. So hemorrhage on the battlefield then, have a look at this graph. What's interesting about this is that all of the potentially preventable deaths, in fact 84% of them, were due to hemorrhage. That makes it the top cause of preventable death. It's also worth noting that only 1/3 of these injuries were in areas where tourniquets could have been used. To put it in simple terms then, in every 100 injuries, 81 will die, 19 could survive, and 15 of them will bleed. Remember that the soldier did have good ballistic protection, although this is counteracted now by the use of high velocity missiles and high explosives, making them more lethal. Interestingly, in a recent study published by the British Army, it's shown that the use of the hemostat Celox has made a statistically significant difference to the outcome of badly injured soldiers. That's published by the Journal for the Royal Army Medical Corps in 2018. The statement states, when comparing patients who had a hemostatic dressing applied versus no hemostatic agent, there was a 7% improvement in survival. Celox was the only individual hemostatic dressing that was associated with statistically significant improvement in survival. So thankfully, one of the good things that comes out of the battlefield is usually something to do with medicine. And military medical services have now realised that more lives could be saved by addressing massive catastrophic hemorrhage. So an additional C has been added in. So before undertaking any of the medical checks, we've added that C in, so it's Dr. C, A, B, C, D, E. The logic behind this is that if the person is experiencing major arterial bleed, this can lead to exsanguination in minutes. No blood means no oxygen to the brain, and so the person could die irrespective of the airways being checked. The decision to add an additional C was a result of an analysis of soldier limb injuries that led to exsanguination on the battlefield. So, Dr. ABC is the original acronym. We all should recognise this from teaching basic first aid. So that's danger, response, airway, breathing, circulation. Taking it up to another level then, Dr. CABCDE. That's danger, response, catastrophic hemorrhage, airway, breathing, circulation, disability or dysfunction, expose and exposure. And this is the approach for prioritising hemorrhage. Note on the right the MARCH acronym. This is mainly used in the United States currently, and it stands for massive hemorrhage, airway, respiration, circulation, head and hypothermia. You can see the correlation between the two. It's slowly creeping into the UK. To this day, however, the Dr. CABCDE approach to emergency care remains pretty much the most reliable and necessary for most situations. This is because a casualty can bleed out in as little as a minute following a major arterial bleed. A 2006 study outlined the scientific rationale for shifting to this new model of Dr. CABC, where evidence of catastrophic hemorrhage was checked before airways, breathing and circulation. By practicing effective first aid using the Dr. CABCDE approach, there's a high likelihood that more lives could actually be saved. So we already know that uncontrolled bleeding is the major cause of preventable death, from a severe injury. And so by taking the Dr. CABCDE approach, first aiders can expect a more successful outcome. Violence and unintentional injuries cause a significant amount of deaths. Human suffering and disability in the WHO European region every year accounts for almost 530,000 deaths. That's 5.7% of all deaths. In England and Wales, it's reported that around 16,000 people die after an injury. In fact, according to the European Statistical Agency, in 2015, just over 1 million deaths were classed as preventable. The concept of preventable deaths is broader, includes deaths which could have been avoided by public health interventions focused on wider determinants of public health. And this includes behaviour and lifestyle. Of these deaths, 160,968 were attributed to violence or assault and unintentional injuries. Just over 16% of all preventable deaths. So essentially, by practicing effective first aid using Dr. CABCDE, more lives could have been saved. So catastrophic hemorrhage then. What does it mean? Well, the Oxford Dictionary defines catastrophic hemorrhage as, and I'm going to break it down into two parts. Catastrophic, involving or causing sudden great damage or suffering. Hemorrhage, an escape of blood from a ruptured blood vessel. So many trauma-related hemorrhage, particularly in the battlefield, are known as catastrophic hemorrhage. And that means the blood loss was caused by sudden great damage or suffering. These injuries ultimately lead to hypovolemia. Hypovolemia. That's a low volume of blood, which is the term we use for decreased blood volume. This ultimately results in hypovolemic shock in patients if we don't treat them rapidly. Hypovolemic shock is a life-threatening form of shock that occurs when individuals lose more than 20% of their blood or fluid supply. And that makes it almost impossible for the heart to pump blood around the body effectively. This ultimately leads to organ failure and death if we leave it untreated or uncontrolled. To manage and treat catastrophic hemorrhage, most medical teams use a standardized and priority-oriented approach, and that usually comes from advanced trauma life support, or the ATLS classifications. This has been widely adopted around the globe since its introduction and categorizes hemorrhaging into 4 classes, which describe the signs and symptoms of shock. Catastrophic hemorrhaging begins at class 1, and first aiders should try and stop all bleeding before it progresses to a further class. So here are the 4 classes of hemorrhage then, via the chart. Class 1, less than 750 mils of bleeding. That's less than 15% of your total body volume. Remember that 5.6 litres? Your pulse rate's going to stay relatively normal. Somewhere between 60 and 100 is relatively normal. The blood pressure will be normal. Respiratory rate will be normal. Skin colour and central nervous system symptoms. It's gone to class 2 then. 750 to 1500 mils of blood loss. That's nearly 30% of your total body volume of blood. You notice now the pulse rate's going to start to increase, usually just above 100. The blood pressure may start to drop, although you might not notice that at all. Respiratory rate going to start to increase. By now the skin will be quite pale, and it says you're going to be anxious. Class 3 hemorrhage. 1500 to 2000 mils. That's nearly 2 litres. Total of nearly 40% of your blood loss, in fact. The pulse rate is definitely going to increase and probably be above 120. The blood pressure, you may again notice that decrease, but your body's trying to maintain it. Respiratory rate is going to carry on increasing, and in fact, it'll get shallower as well. The skin colour, probably by now, will be quite white. And the central nervous system, I would say the patients can be quite confused, but not necessarily will happen. And at class 4, greater than 2 litres of blood loss. That's greater than 40% total body volume. The pulse rate is going to increase well over 140. blood pressure will decrease. Respiratory rate, massive, greater than 35, if at all detectable at that point. The skin colour will be very, very pale, in fact, very white, in fact. The patient usually be lethargic at that stage. Thinking about this, I've been to patients that have had pulses of over 165 that have lost 2 litres on scene. And they've been quite combative throughout the whole journey into the major trauma centres. Where's class 5 then? Notice there isn't one. So what's going on here? This is called compensation. So the body reacts to blood loss by shutting things down. Peripherally, we become shut down, don't we? And that's why skin colour changes. Baroreceptors, vasoreceptors recognise this fall in blood pressure. They recognise the decrease in oxygen levels and try and increase everything. They speed the pulse up. They will speed up the respiratory rate. Compensation. Very rapidly, though, at the end of that compensatory period, we decompensate. And that decompensation leads quickly to death. So to manage catastrophic hemorrhage, then, emergency responders can follow a stepwise approach. And we've developed this in line with guidelines outlined by a number of professional and authoritative bodies, including the European Research Council and the Faculty of Hospital Care. And this is inspired ultimately by the good Brigadier Tim Hodgett's ladder of hemorrhage control. Our stepwise approach draws on the best medical evidence and research currently available. This is evidence-based medicine. The stepwise approach to hemorrhage control begins with identifying the catastrophic hemorrhage. To do this, you may need to remove clothing or the patient's jackets to expose the wound, but time is crucial in stopping the bleed. So if possible, remember to wear gloves. That's to protect yourself and obviously try and reduce risk of infection to the patient. You then need to apply firm, constant, and ideally digital direct pressure to the wound. And again, ideally using your non-dominant hand. This frees up your dominant hand. For most of us, that's his right hand, do other things. Again, doing this will make it easier for you to assess the injured person and the type of bleeding they're experiencing. We're going to contemplate the use of a pressure dressing. Is that going to work? Remember the limitations on pressure dressings. Is it in an area that's going to be used for hemostatic gauze? So we're going to contemplate the use of that. Or do we need to use a tourniquet as a last resort? So this approach to hemorrhage control is still written and stressed in many emergency medical service textbooks. However, if persistent bleeding saturates a pressure dressing, then the pressure isn't being focused on the source of bleeding. Pressure dressings should apply pressure directly to the site of vascular injury. The application of additional layers of dry dressing results in more diffuse and therefore less effective pressure atop the existing non-functional one. This continued addition of dry dressings only results in soaking up even more blood, backed up to a litre of blood through 2 dressings. The sponge-like effect draws blood from the wound and ultimately wicks away clotting factors from the site of the vascular injury. Additionally, small motions that naturally occur between the patient and dressing disrupt the clot that may be forming in the gauze matrix. Blood and the resulting hematoma responsible for sealing the damaged vessel is better left inside the body and not outside. About 80 millimeters of mercury can be applied by pressure dressings, and that's not enough to stop the 120 millimeters of mercury that arteries need to be occluded. So hemorrhage control techniques, tourniquets. We would normally only apply a tourniquet as a final step, but we're going to cover it now so that hemostat, which will be used more frequently, are covered at the end before the demonstrations. We're going to explore tourniquets a bit more closely, as there are a number of factors to consider before using them. So we're going to talk about the indications, that's when to use them, contraindications, when not to use them, and considerations in the use of tourniquet for hemorrhage control. We're going to talk about the steps required to control major hemorrhage with a tourniquet. We're going to know how to use the documentation communication requirements. We're also going to explore a few different types of tourniquets that are on the market, and commonly used ones. So before we go through the objectives, we'll quickly look at the history of tourniquets and how they first came into existence. Tourniquets have been used for as long as warfare itself, and they're a constricting or compressing device that can be used to control venous and arterial circulation. Pressure is applied circumferentially, that's all the way around, and that goes on the skin and the underlying tissues of a limb, and that pressure is transferred to the walls of vessels, and it causes them to become temporarily occluded. Think about that statement on the left there. Sir Gilbert Blaine in 1785, he actually said that in battle, each Royal Navy sailor should carry a tourniquet. We think they're modern, but they're not. Tourniquets, according to the Faculty of Hospital Care, Royal College of Surgeons, tourniquets should only be used as a last resort. So after all other step measures have failed, except in complete traumatic amputation. So in this instance, a tourniquet should always be applied. When we just think about traumatic amputation, does the limb need to be completely missing? If we've mangled a limb inside a machine, for instance, would you put a tourniquet on there? Answers in the chat room. So again, according to the Faculty of Hospital Care, there are no true contraindications to use of a tourniquet for a life-threatening hemorrhage. So when direct pressures fail or is not practical, tourniquets must always be used, and they must be used correctly or not at all. Considerations. It's important to bear in mind the considerations for using them. Tourniquet application is painful, and I've actually witnessed soldiers trying to rip tourniquets off when they've got a leg missing. It hurts like hell. Have a go. Tissue damage. It does tend to be temporary and minor, and it's definitely something worth considering though. And the only person that removes tourniquets are medical control. That'll be the surgeon when he's there ready and waiting with his clips to stop the bleeding. Tourniquets fall into 5 main types. Windlass tourniquets, these use a twisting rod to increase the pressure. Examples include the combat application tourniquet, or the Special Operations Forces tourniquet, or the TMT tourniquet. Ratcheting tourniquets, these use some sort of locking ratchet to increase the pressure. Example of this would be the MAT or the RMT tourniquet. Got rubber tourniquets here. These use a stretch of rubber to increase pressure. An example of this might well be the SWAT-T, stretch, wrap and tuck, or in fact the ACT tourniquet. Pneumatic tourniquets, these use compressed air to increase the pressure. They're mainly used in hospitals. Think about things like a blood pressure cuff. Then we've got improvised tourniquets. And we're using what things are actually available to us at the time. And it might just be a necktie or a scarf with a stick inside it that we've stuck inside to act as a windlass to increase the pressure. There are only certain areas that tourniquets can be used. These are known as compressible areas. So the 2 arms and 2 legs. So the top of your leg, the thigh, or the bottom of the leg, the calf. But we wouldn't use them on junctions or joints, like the groin or the knee. It's here in the knee, for instance, that the femoral condyles are located. And the arteries and veins tend to run between the femoral condyles. Have a look at area B on the diagram. Condyles are positioned to protect them arteries and veins, meaning if a tourniquet is placed here, it is constricted and it's not capable of fully stopping the bleed. If you are managing a complete amputation, then you should apply the tourniquet as distal as possible to the wound. That is as far away from the heart as possible, ideally 2 inches above the wound. Apply them tight enough to stop the hemorrhage. If this doesn't happen, you'll need to retighten or reposition the tourniquet. Following this, if bleeding still continues, apply a second tourniquet above the first and tighten that until bleeding stops. It's very common when using a tourniquet for a bit of oozing at the wound site to occur. So to recap, 2 arms, 2 legs, 2 inches above the wound. So why is positioning important? When a major blood vessel is severed, it retracts. By placing a tourniquet approximately 2 inches from the wound, the tourniquet will be able to provide the necessary circumferential pressure to occlude the vessels, and it still accounts for the ongoing retraction. In July 2017, the Faculty Hospital Care had a position statement change. Originally, we talked about tourniquets going around single bones only. Since then, through again medical evidence, we've realised that you can actually apply tourniquets to double bones and still occlude the vessels. Reason for this being is more than likely that the bones have been broken to start with by the damage. But even if they don't, you can still occlude the vessels underneath them. So it's the same principle for the arms. Tourniquets can also be applied there, and they should be applied as distally to the wound as possible. Again, remember that 2 arms, 2 legs, 2 inches above the wound. And that's both on single bones and double bones. And again, avoid the joints. So how do we apply it? Well, if you're managing a complete amputation, then you should apply a tourniquet as distally above the wound as possible. Remember that, 2 inches above the wound. Apply it tight enough to stop the bleed. If it doesn't happen, then tighten it some more or reposition. You may be too close to that joint. Following this, if the bleeding still continues, you can apply a second tourniquet above the first and tighten until bleeding stops. It's quite common when doing this for some oozing at the wound site to occur. Remember, bones can't be compressed and bones are highly vascular, so you will get oozing from the bone ends, and that's the medullary canals. Documentation requirements. It's quite essential that all caregivers involved in the care of a patient are notified that a tourniquet has been placed. More importantly, record the time, and most commercially applied tourniquets actually have an area to put the time on there. This allows the surgeons later on in the case pathway to note how long the tourniquet was applied for. Medical professionals will have a particular form for these procedures as well. These are patient care records, patient report forms. If you can't write on the space on the tourniquet for the time, it's always a good idea to write a big T on the patient's forehead with the time alongside it. Please, again, any questions so far, stick them into the chat room and we'll complete them shortly. So earlier we touched on hemostatic agents very, very quickly when we went through the stepwise approach, but now we're going to talk about the Celox range, how it should be applied and what they're capable of. So hemostasis is defined as stoppage of bleeding, hemorrhage or blood flow through a blood vessel or body part. Hemo meaning blood and stasis meaning stop or straight away. Hemostatic agents work by improving primary hemostasis. They stimulate fibrin formation or inhibit fibrinolysis. Hemostatic, hemo meaning blood, stat meaning straight away. So what is Celox? Celox range of hemostats are available in the form of granules used as a standalone product, through an applicator, or in fact on a gauze. They contain a proprietary chitosan derivative in the form of flakes. Chitosan is a natural polymer that can be extracted from a variety of sources. Shellfish, crab, mushrooms in fact. The degree of efficacy is dependent not only on the source, but importantly on how it is actually activated onto the hemostat. Celox's composition is protected by 3 international patents. Celox works by a process of absorption and dehydration. It does this completely independently of the body's clotting mechanism and without exothermic reaction or a heat type reaction. and it's not going to damage any surrounding tissues. For those that remember, back in 2003, and I certainly do, in Iraq, we used a product that contained zeolite. And zeolite rapidly adsorbed fluids from the blood. It increased factor 12, thereby speeding up the clotting mechanism. As a result of that adsorption, though, it also created an exothermic reaction. 120-degree temperatures have actually been recorded in there. So it almost cauterized the wound at the same time. Celox has never done that, not exothermic in any way. Anybody remember this nightmare from earlier on? So we talked earlier about how blood clotting works in the intrinsic clotting pathways. Just to remind you all, the intrinsic pathway is activated by trauma inside the vascular system. And this is activated by platelets, exposed endothelium, chemicals, or collagen. If you think about any factor being in there that's missing or being upset, these are called coagulopathies. And these are going to upset the whole pathway. So where does Celox work on that intrinsic extrinsic pathway? Well, the simple answer is it doesn't. Celox works independently of these pathways, and it will work regardless of any clotting impediment. So earlier we looked at the trauma triad of death, and in fact the complex relationship between the three conditions. However, Celox even works on anticoagulated blood and stops hypothermic bleeding. So for all hemostatic agents, how do we apply them? We need to first identify catastrophic hemorrhage, fully expose the wound, identify the point of bleeding, and apply that digital direct pressure, and fingertips going in there, point of pressure straight onto the bleeding point. If we can, we're going to swab some excess blood away from the wound, and that's more to help identify that we're right on top of that point of bleeding. We're going to pack the product directly onto the source of bleeding, apply firm pressure, and if we're using something like Celox Rapid, for 60 seconds or until bleeding stops. Secure it with a dressing, and ideally tuck the packaging into the bandage to take to hospital. That way, once the patient's at hospital, the doctor knows what product's being used. And let's get the casualty to hospital. So let's have a look at the full Celox product range, and in fact, the application and uses of each one. The Celox products have been around since 2006 and have saved the lives of many soldiers and civilians since then. They use a high quality chitosan formulation to be fast acting, it's safe and very highly effective. It works independently of the body's classic coagulation pathway, and it's not exothermic, doesn't generate any heat. They rapidly promote clot formation through absorption and dehydration, and they form that gel-like pseudo-clot. Celox granules work even in challenging cases, and that's including hypothermic patients and anticoagulation meds, and more the trauma-induced coagulopathic patients, those in the trauma triad of death. Celox Granules. These are the original Celox product, and again they're proven to save lives and reliably stop arterial bleeding. They come in a 15-gram sachet, and the Celox granules mould to the shape of the wound, and they get firm pressure direct to the source of the bleeding, even in complex shaped injuries. They can be applied to arterial, venous, life-threatening bleeding, in addition to complex and deep wounds. If you look up there under a microscope, they have a very large surface area, and this helps them absorb a great deal of liquid. So how do we use Celox granules? Identify catastrophic external hemorrhage, obviously most important. Expose the wound completely. Identify the point of bleeding and apply digital direct pressure to the point of bleeding. Swab any excess blood, if you can. Pour the granules directly onto the source of bleeding. Cover, Quite important, if you don't cover and just apply a gloved hand, they will stick to your hand. Apply firm pressure now for 5 minutes. 5 minutes. And we do that until bleeding stops. Secure with a dressing and maintain that pressure. And you're going to throw away any remaining Celox granules. And you're going to get the patient to hospital. Celox A, the applicator. For small entry wounds, narrow track entry wounds, first aids may find they need an applicator for the granules. Upon application, the granules, when poured, just pool on top of the wound, and they don't get into the actual point of bleeding. To overcome this, Celox has developed an applicator that delivers the granules deep into even small wounds. The benefits of this is that it can get deep into tissue with wounds such as stab and gunshot. They hold up to a pre-filled syringe with 6 grams of Celox granules, and it still requires 5 minutes of compression following application. The one place you would never put granules or gauze is in cavities, and it's quite important. So again, identify catastrophic external hemorrhage. Fully expose the wound. Identify the point of bleeding and apply digital direct pressure. For this, you may need to stick your finger into the hole. Prepare the applicator. It's in 2 parts. Pop the safety cap off, which is the blue part. Pop the cap off at the top and push the plunger into place. You'll see more of this on the demonstrations. Once your finger's in the hole, you're going to make sure, one, you're not in a cavity and you know the depth and track of the wound. You're then going to plunge the granules deep into the source of bleeding. Again, cover and apply firm pressure for 5 minutes or until bleeding stops. Secure it with a dressing to maintain that pressure, and again throw away any remaining Celox. Get the patient to hospital with the packaging. Celox Gauze. The UK MOD had said that they liked the hemostatic action of the granules. However, all their trauma protocols were based on packing gauze into trauma victims. As a result, Celox Medical developed Celox Gauze. It's a gauze that includes the Celox granules as the active ingredient. It's a non-woven gauze. Celox Gauze is manufactured using a non-woven gauze so that it can expand on wetting when in contact with blood products. This helps to maintain contact within the wound and fill the wound space, creating a tamponade or pressure effect. It's then laminated. The gauze is laminated with the Celox granules, which are bonded to the surface of the dressing so it can come into contact with the blood at the source of bleeding. Any shedding of Celox granules from the gauze is normal, and that happens during packaging, and it's been accounted for. Laminating the granules onto the surface ensures that the granules come into contact with blood well within the wound. And this is very different to other chitosan products, which may use woven gauze substrates that are impregnated with chitosan and require blood to be soaked into the dressing before coming into contact with the chitosan actually in the dressing. The gauzes now require just 3 minutes of compression following application. 3 minutes. So how do we use them? Again, identify external hemorrhage. Fully expose the wound, identify the point of bleeding and apply that firm digital direct pressure. Swab out any excess blood if you can. Pack directly onto the source of bleeding. And we'll cover this a little bit more detail when we go on to the practical aspects at a later date. Apply firm pressure now for 3 minutes or until bleeding stops. Slowly release it at the end of 3 minutes and check that the bleeding stopped, and then secure with a dressing. This again maintains pressure. Throw away any Celox gauze and put the packaging inside the bandage. And let's get the patient to hospital. So although we were happy with how Celox works, we searched for ways to improve the speed of action. So we appreciate the difference the time makes when using the products in extreme environments. 3 minutes is a long time during a firefight. And this is one of the reasons we developed the new product Celox Rapid. Celox Rapid features the same excellent hemostatic properties standard Celox, with the addition of a special ingredient that makes it stick together faster when activated. It sticks to the wound walls and to the gauze itself, which makes holding the important tamponade even easier. It should be used in exactly the same way as the other products: insert, pack and press. For this product, however, the first aider is only required to apply pressure for around 60 seconds. And that gives the first aider the advantage of being able to have more time to move on to other injuries, casualties, and actually less time on scene. So Celox Rapid, how to use that? As with them all, identify catastrophic external hemorrhage. Fully expose the wound. Identify the point of bleeding, apply that digital direct pressure. Swab any excess blood if you can, and pack directly onto the source of bleeding. Apply firm pressure, this time just 60 seconds. Or again until bleeding stops. Secure it with a dressing, a pressure dressing, and this maintains that pressure, and again discard any remaining Celox. Tuck the packaging inside the bandage. Let's get the casualty to hospital.
Introducing Celox Rapid, the fastest hemostatic gauze for life-threatening hemorrhage. Uncontrolled hemorrhage remains the main cause of death for civilian adults under the age of 40. Stopping a life-threatening bleed can challenge even experienced paramedics and emergency responders. Help is often too far away, or the casualty bleeds to death before help arrives. In some situations, life-threatening bleeding can lead to exsanguination in under 5 minutes. Fast and effective treatment is needed to save lives. Celox is proven to stop life-threatening bleeding fast and is trusted by militaries, emergency services, and health professionals the world over. Celox Rapid is the fastest-acting hemostatic gauze that can stop life-threatening bleeding with 60 seconds of compression. Not only does Celox Rapid reduce the total treatment time, it also packs faster. Its 5-foot length gauze fills the same volume as competitive 12-foot hemostatic gauze products, but it reduces the packing time, saving over 2 minutes from start to finish. Celox has become one of the main products currently used by the UK Armed Forces. Some hemostatic agents work by accelerating the body's own clotting factors, but these can become compromised in severely bleeding casualties. Celox is different. It works independent of the blood's intrinsic clotting mechanism. Celox works physically at the source of bleeding. With Chito-R chitosan, Celox Rapid swells and gels to form a coherent pseudoclot and stops life-threatening arterial and venous bleeding with 60 seconds compression. Celox Rapid is presented in a lightweight, low-cube foil pack that has a 5-year shelf life and no allergies reported to date. The following training video is a guide to using Celox Rapid to pack a wound according to the product indications and packaging instructions. When responding to a casualty, it's important to identify catastrophic external hemorrhage as soon as possible. Fully expose the wound, identify the point of bleeding, and apply direct pressure to stem the flow and gain control of bleeding. If blood has pooled in the wound, remove the excess using plain gauze, swabs, or whatever material is available. Celox Rapid is indicated for life-threatening bleeding. Familiarize yourself with the product's packaging. It has 4 tear notches, 1 at each corner. While maintaining pressure on the wound, open the pack and remove Celox Rapid from the packaging. Take one end of the gauze and tightly pack the unfolding Celox Rapid directly onto the source of bleeding. Continue packing the wound while maintaining pressure at all times, feeding in the Celox Rapid until the wound is filled beyond the skin level. For larger wounds that are not filled up by a single Celox Rapid, use an additional Celox Rapid or another plain gauze to fill above the skin level. As soon as the wound is packed, apply firm, constant pressure for 60 seconds. Visually check for bleeding around the dressing while still maintaining pressure. If bleeding has not stopped, reapply pressure until bleeding stops. If necessary, cut or tear off excess Celox Rapid before securing the dressing in place. Wrap the wound using bandaging or a pressure dressing to secure and maintain pressure. Discard any remaining Celox Rapid. Maintain pressure at all times. Remember to bandage tightly to maintain direct pressure through to the hemostatic. Record that Celox has been used in the wound. Place the packaging inside the bandage for the next stage of care. Check periodically and reassess the wound for bleeding until reaching the next stage of care. Remember to follow these steps when applying Celox Rapid. Identify catastrophic external hemorrhage. Expose the wound. Identify the point of bleeding and apply direct pressure. Swab excess blood. Pack onto the source of bleeding. Apply firm pressure for 60 seconds or until bleeding stops. Secure with a dressing to maintain pressure and discard any remaining Celox Rapid. Tuck Celox packaging into bandage. Transfer the casualty to the next stage of care. Celox Rapid is presented in a lightweight, low-cube foil pack that has a 5-year shelf life and no allergies reported to date. It works with 60 seconds compression, stopping life-threatening bleeding fast. The technology has been proven successful to stop hypothermic bleeding. Celox Rapid, the fastest hemostatic gauze for life-threatening hemorrhage. Made to save lives.
So looking at the map of the world here, flattened out, who uses Celox? Whereabouts in the world do you think Celox is used? What industries use it? Well, here we go. Celox is recommended by the US Committee on Tactical Combat Casualty Care, COPC. It's the first choice of products for UK MOD. It's used by armed forces in the US, Spain, Poland, Malaysia, Jordan, Libya, Italy, just to name a few. It's used in the mining, oil rigs, ambulances across the world, and in fact across most of the UK. It's used in A&E departments, within hospitals, law enforcement and firearms officers up and down the United Kingdom. More importantly, it's also used now by first aiders and carried in their own equipment. Let's recap. Celox successfully stops bleeding from arterial injuries, gunshot wounds, road traffic injuries, blast injuries, crush injuries. Clinical references are available on all of these injury types. It's the only hemostat proven to work on hypothermic casualties, as well as anticoagulated coagulopathic patients. Remember that blood loss leads to hypothermia, even in hot conditions. Think about this, acute traumatic coagulopathy. So Celox works independently of the body's normal clotting mechanisms. Celox Gauze are the most effective hemostatic gauzes, with published independent results in real-world use for both military and civilian. So let's look at some frequently asked questions. So here's one of the biggest ones that comes up. Is there any reaction in patients with a shellfish allergy? Well, to date, there's been no known or suspected allergic reactions resulting from the indicated use of Celox. There has been independent testing carried out, and it showed no allergic reaction on volunteers who actually had a positive allergic reaction in response to fish or shrimp prick tests. In reality, remember how Celox has been made. They use a chemical process called deacetylation. That deacetylation removes the proteins from the prawn shells. It's proteins that cause allergic reactions. If there are no proteins, therefore there are no allergic reactions. I hope that makes sense. So what happens if residual Celox granules remain in the injury? Well, chitosan consists of glucosamine and N-acetylglucosamine. These are naturally occurring sugars inside the body, and your body can actually digest them over a period of time. Remember, it's been in use since 2006, and there's been no medical adverse events reported. The ease of removal of the agent at the time of further medical intervention is quite important. Some marketed products, such as Woundstat, for instance, have been shown to be particularly difficult to remove, and they require several washouts, even after a small portion of the products have been remained. Celox is vastly different to that. When washout has been complete, it is efficiently removed by irrigating the wound. So Celox is designed and licensed for pre-hospital use only. It would work well in many other surgical interventions though, but it's not approved for this use. Surgical use is classed as off-license. Surgeons have used it, and I've come across quite a few examples of them using it. Do not eat. Well, a bit of common sense, don't eat it. If you do ingest it, drink lots of water to avoid any discomfort. It'll more than likely just block you up for a couple of days. Don't apply to the eyes. Okay, the surface of your eyes is liquid, and all it's going to do is irritate them slightly. It's not going to burn the corneas out or anything else. If it does occur, then just flush with water for at least 5 minutes. It's a sterile product for single use. Once you've opened that pack, it's not sterile anymore. And I have come across incidences of people opening it, using a couple of pieces, and then sealing it back down again. It's not good. It's not good practice. And actually, once you've opened the pack, it becomes open to atmospheric moisture, and that'll soak up fluid. It's single use only, just remember that. And it should be stored used at temperatures of 60 degrees and 40 degrees C. It's had 3-4 studies done, and they've all been completed with no detrimental results. How do we remove Celox then? Well, granules, scoop out the gel plug and remove any loose surface granules, and irrigate it liberally with lots of saline. Gauze and rapid, very similar to the granules. You should remove the gauze, remove any loose surface granules, and irrigate it liberally with saline. If you need to, you might need to re-moisten the dressing. Just use some normal saline, and that'll ease removal. So in summary then, why Celox? Well, hemorrhage is the leading cause of preventable death, and this is why we need hemostatic agents, just like Celox. Any questions? Let's go on to the chat group and answer some then.
Thanks, Tony, for that. We'll just wait a few minutes to see if anybody does have any questions. Do feel free to pop them down in the chat box. There's lots to learn from that. We've been working with Celox for 11, 12 months directly now, and I'm still learning stuff from Tony, and every time I meet Tony, I seem to learn something new. So while you've got him here, do feel free to ask any questions. I will share in the chat box as well the code for 20% off all the Celox products on our website. That's until the end of November, and do feel free to use that. I'll also pop our email address in there, and if you've got any questions or questions for Tony, then feel free to get in touch with me and I can pass them on to Tony, and we'll probably share those responses on our social media as well. Thanks, Dave. Good to know that you're promoting Celox on your courses, and do feel free to drop us an email about how we can help you with that as well. We work with a few trainers